Hello everyone, welcome to the channel. Today we will learn about screening of diseases. It is a very important chapter, and in this presentation I'll talk about the concept of screening, what is iceberg phenomena, and what are the differences between a screening test and a diagnostic test, what are the various types of screening and its uses, and what are the various screening which we are doing under national health programs, and what are the criteria we need to know for the disease which is to be screened, and what are the criteria for a test which is being used for screening. Then the concept of sensitivity and specificity, how to calculate it, and the advantages and limitations of screening procedure. And at the end, we'll do some MCQ related with the same topic. So in screening, we are doing the search of unrecognized disease or defect by means of a rapidly applied test or the examination or procedures in apparently healthy individual. So I have broken the definition of screening under 3 parts, and all these terms are very important. So it is a search of unrecognized disease by means of rapidly applied test and in apparently healthy individual. Means the person in which we are applying the screening, they are not showing any kind of sign and symptom, they are apparently healthy. We will not use the term healthy individual, apparently healthy. And we are trying to search for unrecognized disease burden, means it is not evident, and it is by the means of rapidly applied test or examination. So it means the test which we are applied in the screening should be simple, quick and effective, and that can be applied to a very large population, and they should be minimally invasive or non-invasive, so that our compliance can be improved, and minimal resources should be required for these type of testing. So from where the concept of screening arises is based on the iceberg phenomenon of disease. So what is an iceberg? So in iceberg, only a small portion of the ice is visible, and rest of the portion, a large portion, is submerged in water, which we cannot see. So the tip of this iceberg represents the clinical disease, and the submerged portion is the hidden burden of disease, which we can't see. So the cases we see in our hospital that represent the tip of the iceberg, and the hidden burden of disease mean the cases which are not diagnosed, which are asymptomatic, the latent cases, or the carrier. Because they are not showing any kind of sign and symptom, they are not being considered in the burden of disease. So by screening, we are trying to look after this submerged portion and the hidden burden of the disease. So what will happen after we apply your screening test? So we apply screening test in apparently healthy individual. The screening test result may be positive or negative. If the result is negative, we need to do the periodic screening. If the result is positive, then the subject is directed to diagnostic test for the confirmation of disease. If the diagnostic test confirm the presence of disease, then we label that person as a disease and we offer them the therapeutic options. If on diagnostic test the person is not diagnosed, then we also need to do the periodic screening in that individual. This is showing the various levels of prevention and the natural history of disease. So before the appearance of sign and symptom, there is a preclinical phase, and in the clinical picture there is appearance of sign and symptom. Here we do the diagnosis and we do provide the treatment. So health promotion and specific protection comes under primary prevention. In secondary prevention, we want to do the screening and early detection, and tertiary prevention includes the rehabilitation and disability limitation. So the screening lies in the secondary prevention. That is a very important MCQ. You will get the 4 options, like screening comes under primary prevention, secondary, tertiary, or the quaternary. So the screening comes under your secondary prevention. So any kind of question related with screening, like screening of PP, screening of pap smear, screening for carcinoma breast. So all these example can be quoted as an MCQ and they will come under your secondary level of prevention. We will see the difference between the screening test and diagnostic test. So screening is usually done on the apparently healthy individual, while the diagnostic test is done with those with indication or who are sick. It is usually applied to groups of people when we are doing the screening, but usually the diagnostic test is done on a single patient and will consider all the disease depending upon the sign and symptom of that particular patient. Its test results are arbitrary and final. And diagnosis is not final. Obviously, we need to do multiple tests for the confirmation of diagnosis. We need to take the history, physical examination, multiple diagnostic tests for the diagnosis. And test results arbitrary, final ka matlab final means we need to consider that the person is either positive or negative for the screening. It should be based upon one criteria or the cutoff point. It means before doing any kind of screening test, we need to decide beforehand what will be the criteria for positive screening test, what will be the criteria for the negative screening test. That means if we are going for a screening camp for diabetes, we will decide the cutoff point, whom to take as diabetic positive, whom to take as diabetic negative. So it is decided beforehand. So we should have a clear-cut criteria whom to take as a positive, whom to take as a negative. But it is not in the case of diagnostic test. The diagnosis is usually a combination of multiple things, multiple tests on the basis of a sign, symptom and the laboratory finding. So a diagnostic test obviously is more accurate as compared to the screening test. It is not a basis of treatment. It means only on the basis of screening test, we will not provide that patient treatment. We need to confirm it after offering a diagnostic test if the person is screening test positive. But obviously when we are doing the diagnostic test and it is pointing towards any kind of disease, then we will provide the treatment based upon the result of that diagnostic test. What happens in diagnostic test? Usually a patient comes to the hospital with some sort of complaint. We do the physical examination. We subject them to the diagnostic test. But the screening is usually is not comes from directly from the patient, and sometimes the government advise us to do some screening, or so it is not always that it comes from the part of the patient. Onset of disease, but we cannot detect the disease even by the screening methods. This is the usual time of diagnosis. By this time the patient is already having the sign and symptom. So the patient may itself come for the advice of the healthcare provider and the disease is very obvious. First possible point indicates the earliest point at which the disease can be diagnosed before the appearance of sign and symptom. So when we are screening for the disease and we want to diagnose it before the appearance of usual time of diagnosis, it should be before the final critical diagnosis. It means at this point there is no point of diagnosis the disease if the disease is already in advanced stage and sometimes the irreversible changes have been made. So our screening time is between the first possible point, the earliest possible point from which the disease can be diagnosed, and before the final critical diagnosis. So lead time is the advantage which is gained by the screening. So this is the outcome if there is a no screening, and B is the outcome when the disease being diagnosed early as a result of screening program. So B minus A is the outcome of screening program. Lead time is defined as the interval between the point at which the condition is detected through the screening and the time it would normally have been detected due to the appearance of sign and symptom. So the lead time is the time duration between the first possible point and the usual time of diagnosis. So what is lead time bias? Sometimes if early detection has no effect on the course of treatment, then it will be like giving the patient a few more years of sickness and apprehension rather than the health. In such cases, it is possible that the screening through earlier detection will advance the time of diagnosis, but without delaying the time of death, so thereby increasing the diagnosis to death time. But it tend to show increased survival among the screen group as compared to the group not given the screening test. So it may happen if there is no effect of treatment, or the successful outcome does not occur even after having the treatment. Now coming to the various types of screening. So first is the mass screening. As the name implies, mass screening means we are applying screening test to a large unselected population, regardless of the probability of having the disease in condition. For example, we have to do some screening in a village. So we will select the whole population of the village. We have taken all the school children for the visual defect, or we have screening all the newborns for some congenital defect. So this type of screening, that is a high risk screening, also known as a selective screening or targeted screening. As the name indicates, high risk screening means we are selecting the people who are having a high chances of harboring the disease or a particular high risk group for any kind of condition. So in mass screening, we have selected all the population regardless of their risk. But here we have selected only the high risk group in the population. So example can include if you want to diagnose diabetes or the hypertension or the familial cancer. So we are taking only that population who have a family history of these kind of cancer. Or if we want to diagnose the fetus for Down syndrome, we have selected only those mother who already have a baby with a Down syndrome. So we have selected the population with high risk group. Now coming to the multiphasic screening. In this screening, what we are doing, we are taking 2 or more screening tests in the combination, and which is being done for a single disease. For example, when we are screening in a person, we are doing chemical, hematological test, we are doing the blood test, LFT, audiometry, visual acuity, urine examination, ultrasound. So all these are done for the diagnosis of single disease. So we have to remember we are using 2 or more multiple screening tests in combination in a large number of population, and it is being done for the screening of single disease. Next type of screening is opportunistic screening, which is also known as a case finding screening. In this, what we are doing, suppose a patient comes to the hospital for some particular reason, and then we utilize this opportunity, and according to the risk group of that particular person, we screen them for different conditions. So the main objective is to detect disease and bring patient to the treatment. So for example, any patient comes with a complaints of stomach ache or headache, and seeing the age, like he is 40 plus, so we can screen him for diabetes, or we can screen him for high blood pressure. So we are utilizing the opportunity that the patient is coming to the hospital. Now what are the uses of screening? So screening is used for the case detection, as we have seen till now. So when the people are screened for their own benefit, like in the cases of disease like cancers, diabetes, hypertension, it is known as a prescriptive screening. Sometimes the people are screened for the benefit of others, and it is being used for the control of disease. So example like HIV, STI. So it is known as a prospective screening. Like in the case of COVID, when there was COVID and the people were moving from one state to another, the government has advised screening of the immigrants. Screening in the case of prospective screening may be done by the agencies or the government for the benefit of others. So screening can also be used for the research purpose when we don't have too much literature about the natural history of diseases. So to frame how the disease is evolving, we can also use screening for that. And when we are doing screening, we are also educating people how to take care of them. Few examples of some screening tests, like we do FPS for the diabetes, blood pressure for hypertension, pap smear for cervical cancer. For colonic cancer, we do the fecal occult blood. Now coming to the some examples of screening which the government is doing under various national health program. The first example is under Rashtriya Bal Swasthya Karyakram, that is RBSK. The target children we have is from 0 to 18 years, and we screen for 4 Ds, that is defect at birth, defect for diseases, any kind of deficiencies, and developmental delay including the disability. And how we are doing that? So how they are being screening? They are using mobile health team, and these team conduct periodical school examination and screening at various Anganwadi centers. Another example is in National Program for Prevention and Control of Non-Communicable Disease. We are screening all the individual above the age of 30 years for the screening of hypertension and diabetes, and we also screen them for oral cancer, breast cancer, cervical cancer. And what the mode we are using is we are doing population based screening through health and wellness centers. Another example is in National Program for the Control of Blindness and Visual Impairment. Our target group is all the age group and school children and elderly as well. And we screen them for refractive errors, cataract, glaucoma, and diabetic retinopathy. So we are doing school eye screening camps and the screening in various vision centers as well. In NTEP, we are screening for tuberculosis, and we are screening them in the general population as well as in the high risk group, and we are doing both active as well as the passive case finding. So passive means when the patient report to the hospital with the symptoms of tuberculosis, symptoms of cough, weight loss, and active when the field worker are going to the field and they are searching for the cases. So now coming to the disease which to be screened has some criteria which need to be followed. So for selecting any disease for screening, it should be an important public health problem and its prevalence should be high. Prevalence means the old plus new cases. And there should be a recognizable latent or an early asymptomatic state so that we can utilize this period. The natural history of the disease should be known, and it should be clear that what will be the latent period, and it should be a test which can detect the disease prior to the onset of sign and symptoms. Screening, there must be facilities for the confirmation of diagnosis, and an effective treatment should be there. And there should be an agreed on policy that whom to treat as a patient, and there must be an evidence that proves that early detection and treatment reduces morbidity and mortality, and the expected benefit should be greater than the risk and the cost of screening. Now coming to the test which we are going to use for screening. So there are 3 important subheadings under the test. It should be acceptable, and it should be repeatable, and the validity of the test. And we will see it one by one in the coming slide. Under repeatability, there are 3 types of variation can occur, and under validity, also known as accuracy, we will see how to calculate the sensitivity and specificity. So first criteria is acceptable. So whatever test we are using, it should be acceptable to the people. It should not be very painful, embarrassing, and it should be safe. And obviously there should be cooperation of the community. Second criteria is repeatability. So this repeatability is also known as a reliability or the precision or reproducibility. It means when we are repeating the test, it must give consistent result, right? And we are doing the test on the same individual or material or under the same condition. So it depends upon three major factors. First is the observer variation. Second is the biological variation. And there may be error due to the technical methods which we are using for screening. So under observer variation, there are two categories: intra-observer variation and inter-observer variation. Intra-observer means when the same person is doing the test, he is getting different results on repeating the test. Inter-observer, inter means between two. So it means two different observers are doing the test and they are getting different kind of result. So intra-observer variation, it can be minimized by the taking of average of several readings. Inter-observer variation means suppose we have histopathological slides, 100 slides, and we have given equal slide to both the pathologists. So in one case out of 100, 70 are being tested positive for the presence of cancer, and in another case, another pathologist have detected only 60. So it means our results are different from different observer when they are doing the test on the same subject or material. Sometimes the variation can be due to the biological variation, because many of the physiological variables like blood pressure, like blood sugar, serum cholesterol, they may vary as per the diurnal variation. Or sometimes when we are in stress, our BP may be raised, है ना? So similarly in the case of hormones, they may peak at different time or they may peak in the morning. So when we are testing that particular hormone or other thing, physiological variable, that may give different result on different timing. And the fluctuation may also be due to the individual who is perceiving the symptom in a different way. Third is, there may be errors due to error in the technical method. Like the instrument we are using is defective, there are errors in the calibration, or the faulty reagent may be inappropriate or unreliable which we are using. So coming to the validity, which is also known as an accuracy. So validity refers to the extent to which a test accurately measures what it meant to measure or claimed to measure. So it is the ability of a test to distinguish who have the disease from those who do not have. So it has two components. One is the sensitivity, another component is the specificity. So before going ahead, I want to just summarize under test category what we have read till now. So under test category, we have three things. One is acceptability, like test should be acceptable, the person, they should be able to cooperate, not embarrassing, it should be safe. Under repeatability, we have three kinds of variation. One is observer variation, intra-observer or inter. Inter means when two individuals are doing, they are getting the different result. Intra means when the same person is doing in the same subject or material, he is getting different result. Second is a biological variation due to the variation of the physiological parameter, right? And in third condition, we are getting error due to the errors in our technical method. Either test is not accurate or there is a problem in the calibration, right? And third component is validity. It is also known as accuracy, and it has two components, sensitivity and specificity. This 2x2 table which is made for the evaluation of screening test. So this side we write down the result of screening test. The person may be either tested positive or the person may be either tested negative. These columns represent the presence and absence of disease. So this column represents the total number of the patient who are having the disease, and this column represents the total number of patients who are not having the disease. This row represents that it is test positive. It means this represents the total number of patients who are tested positive, and the total of this row represents the total number of patients who are tested negative on the screening test. Then the person who are having the disease and they are also tested positive by the screening test, they are known as a true positive and it is represented by A. The persons who are not having the disease and they are also tested negative, they are represented by D and they are known as a true negative. If a person is not having the disease but they are being tested positive by the screening test, it is known as a false positive and represented by letter B. If the person is having the disease but they are tested negative by the test, it is being denoted by the letter C and they are known as a false negative. And this N represents the total number of all the patients who are being tested, like A, B, plus C, plus D. So this column represents the total of all these 4 columns. Now we will understand these terms one by one. So there can be 4 outcomes of a screening test. The first scenario may be true positive. It means the test correctly identifies a person who is having the disease. So, example, a person is having a diabetes test will also be tested positive in screening. Next comes the true negative. It means the test correctly identifies a person as not having the disease. For example, a healthy person tests negative for the diabetes. Third scenario may be false positive. It means the test incorrectly identifies a healthy person as having the disease. Example, a person who does not have the diabetes but he is being tested positive by the test. Fourth scenario can be the false negative. It means the test incorrectly identifies a sick person as healthy and it misses the disease. For example, a person with diabetes tests negative for the diabetes. Now for the validity, as we have learned in the previous slide, it is being calculated by the sensitivity and the specificity. So it is defined as the proportion of the diseased people who were correctly identified as positive by the test. So the proportion of diseased is this, is A plus C, and who are being tested positive, truly positive, is A. So the sensitivity is A upon A plus C into 100. The result of sensitivity and specificity is expressed as percentages. So for example, if the sensitivity of any test is 81%, what does it mean? This means the test correctly identifies the 81% of the people who actually have the disease. For example, if 100 people are having the disease, the test will detect 81 cases out of them, but the test can miss 19 cases. Higher the sensitivity, the fewer are the chances of having the false negative. Then next is the specificity. It is defined as the proportion of non-diseased people who are correctly identified as negative by the test. They are not having the disease, they are also tested negative by the test. So who are the non-diseased person? This is the column of non-diseased people. So the specificity is the proportion of true negative. So it is D upon B plus D into 100. For example, if the specificity is 78%, it means the test correctly identifies 78% of the people who do not have the disease. For example, if 100 healthy people are tested, the 78 will be correctly identified as disease-free, but the 22 may be wrongly classified as having the disease. Other than sensitivity and specificity, we have predictive value of test, and there is positive predictive value of test and negative predictive value of test. So it is useful to know the proportion of patients with abnormal test result are truly abnormal. So the predictive value reflects the diagnostic power of a test, while the sensitivity and specificity reflects the accuracy of that test. The value of a positive test indicates that the probability that a patient with a positive result has in fact the disease in question. For example, if the positive predictive value is 43.3%, it means only 43% of those who have tested positive by the test have actually the disease. Coming to the predictive value of negative test, it indicates the probability that a patient with a negative test result doesn't have the disease in question. For example, if the negative predictive value of any test is 95%, it means the 95% of those who test negative truly do not have the disease. Now let us summarize again this 2 by 2 table. On the left side, we represent the results of the screening test, which may be either positive or negative. This side, we write down the presence and absence of disease. And these are represented by A, B, C, D. And this N represent the total number of A, B, C, D. So in examination, sometimes this 2 by 2 table is being given to you, and you have to calculate the sensitivity, specificity, positive predictive value of test and negative predictive value of test. Or sometime the case-based scenario is being given, and then you have to make a 2 by 2 table by yourself. So what are the steps to make a 2 by 2 table? We will make a table. On the left side, the first step is to enter the screening test, positive and negative. Then you should write the diagnosis part. This is the diseased column. This is the non-diseased column. Then you write down the A, B, C, D. We cannot write in this way. Write A here, B here, then C here and D here. You have to write in the similar way. Then first you mention the true positive column, that is diseased also, and they are positive by test also. Next step would be first write down the true negative. After the true positive, write down the true negative here. They are not diseased and they are tested negative by the test as well. So this is the column of positive. So here is a true positive. So here automatically will come the false positive. So this A plus B is the total positive. So here it will automatically become the false positive. You have mentioned the value of true negative. So this is the column of negative test result. This will automatically become false negative. So in this way we can completely fill this 2 by 2 table. And then we have to remember, when we are calculating the sensitivity and specificity, we have to take the disease in question here and the person who are not diseased. And when we are calculating the positive predictive value or negative predictive value, we have to take the screening test result in the person whom they are positive, in the person whom they are negative. So what was the sensitivity? It is the proportion of individual who are truly positive. So this is a diseased column. Truly positive is A. So it will be A upon A plus C into 100. Specificity was a proportion of true negative. So this is your true negative. It will become D upon B plus D into 100. So I would suggest, rather than remembering all the formula, you should remember only the formulas of sensitivity and specificity. Because if you mug up all these formula and in the examination, students get confused very easily where to put what. So just remember, in sensitivity and specificity, we have to see these columns. If the positive predictive value of test comes, this is a line of positive test result. So positive predictive value will be A upon A plus B into 100. If we have to calculate the negative predictive value, it will be D upon C plus D into 100. And it would be easier for you to remember in exam if you learn in this way rather than the true positive divided by true positive plus false positive. Because in our examination we are very much tensed and we tend to forget what we have learned during classes. Coming to yield, it is amount of previously unrecognized disease that is diagnosed as a result of screening effort. Yield depends upon the multiple factors like sensitivity, specificity, prevalence and the community participation. So higher the prevalence of the disease, high will be the yield. More is the community participation, more will be the yield. And it can also be increased by taking the selective population for the screening purposes. So I have given you two sets of questions. So you can try to make a 2 by 2 table and I have given answers at the end of my presentation. So this question states that a new rapid test for detecting a particular disease is introduced in the rural health center. The test is performed on 950 individuals. So the total of A plus B plus C plus D is 950. The gold standard test confirms that the 200 individuals have the disease. The test detects 180 as positive, of which 150 have actually the disease. So this 180 is the total number of people who are tested positive, out of which 150 have actual the disease. So 150 would be your A value. Additionally, 50 disease individual test negative and 720 non-diseased individual tested negative. So these are non-20 number is non-diseased people who are also tested negative. So these are true negative. So it will, your D will be 720. So try to make a 2 by 2 table and calculate all the values. So sometimes in the question it is not directly given the person who are having the disease. It is question says about gold standard test. It means it is the actual number of patients who are having the disease. This is question number 2. So in a community, 930 people were administered a new screening test for disease. So 930 is A plus B plus C plus D. Total number of patients. Out of 160 persons who were actually having the disease, the test was found to be positive in 130%. So this 130 is your true positive. The screening test was found to be positive in 170% who were actually healthy. So calculate these values. And please write in the comment section that are you able to make a 2 by 2 table on your own. Problems can arise if we diagnose the patient as a false negative or false positive. What is the meaning of false negative? Means they are actually having the disease, but we have told them that they do not have the disease. We have given them a false reassurance. So the patient might ignore the development of sign and symptom. So he may postpone the treatment. Or if he is having any kind of high risk behavior, he may be continuing that behavior because he thinks that he is not having any kind of disease. False positive means the people are not having the disease, but we have told them that yes, you have the disease. So we are giving anxiety, discomfort, and the patient may be subjected to the further diagnostic test, which may obviously cause inconvenience and further expense. And it is a burden to the diagnostic facilities, as we are already sending those people who are not having the disease. So it also brings discredit to the screening program. So coming to the what are the advantages of screening. So obviously we are identifying the disease at the earliest. So early detection and intervention helps in the identification of disease in an asymptomatic stage, and it allows in the timely treatment. And since we are detecting early, we are providing the treatment It increases the chances of successful treatment, improved survival rate like in the cases of cancer. So it helps in the reduction of morbidity and mortality. So early intervention also help in the prevention of progression and further complications of disease like diagnosis of hypertension, diabetes in the earlier stage. It prevents the chances of having the complication. So it will help in the improved quality of life of these individuals. And early management of chronic disease can also help in enhancing the quality of life by minimizing the disability. It is cost effective as compared to the if we diagnose the disease in the later stage, there are a lot of complication, there are disability. So that is obviously a more psychological trauma to the patient, more as a cost also increases in the treating that disease. So it's very cost effective as compared to the treating the disease in an advanced stage. And it has many public health benefits also, as it reduces the burden on the healthcare system by preventing the advanced stage of disease. And it helps in the surveillance of the disease patterns in the population, and it also helps in the public health planning and the resource allocation. So be helpful in the empowerment and health awareness, as we are educating the individual about their own health, leading to a healthier lifestyle choices, and we encourages their participation in the various preventive health measures. So it's not like that we have only the advantages of screening. There are lots of limitations of this screening procedure. So it can give a sense of false positive and anxiety to the patient, and it can also lead to the over-diagnosis and over-treatment. And if we are giving the false negative, false reassurance to the patient, we are delaying its diagnosis and treatment. It is also leading to the economic burden in the cases of low resource setting. If we are doing the wide scale screening, and sometimes it may divert the resources from the other critical healthcare needs, so there may be some resource allocation issues as well. And there is a risk of healthcare inequalities if there is access of screening is not equitable, and there is a potential for discrimination and stigmatization. So we are coming to the last part of the presentation. We will do some MCQs. So what is the primary objective of screening? To diagnose disease, or to diagnose disease early and provide timely intervention, to provide curative treatment, and to prevent all disease. So obviously we cannot prevent all disease, and to diagnose disease we need to do the diagnostic test. So here the best answer would be to detect the disease early and provide timely intervention. Is high risk or selective screening is performed on the entire population or the individual with early signs of a disease, or in a specific group with increased risk of the disease, or in all hospital inpatient. So the answer is specific groups with the increased risk of disease. So all this rest of the three will constitute the examples of mass screening. So here is the question for another name for the opportunistic screening is the mass screening, the case finding, the multiphasic or the multistagic screening. So the answer is case finding screening. So which of the following is not a characteristic of an ideal screening test? So option includes a high sensitivity and specificity, high cost, acceptability by the population, availability of effective treatment. So we have read in the previous slide that it should have a high sensitivity and specificity, should be acceptable, and there must be availability of effective treatment. So the answer would be high cost and complexity. We want simple test, and we usually take rapidly applied test whose results are quickly available. So which of the following is an example of selective or high risk screening? So the option include universal blood pressure screening in adults, screening for cervical cancer in the low socioeconomic status women, annual eye examination for all individual, and newborn screening program. So the answer would be screening for cervical cancer in the low socioeconomic status women. Next question is, if a disease is highly contagious and has a severe outcome, what should be prioritized in screening? High sensitivity, high specificity, high positive predictive value, or the high negative predictive value? So the answer lies that the disease is highly contagious and has a severe outcome. So we do not want a single case to be missed during screening while testing. So the answer would be high sensitivity. So we want to include as many as individual because we don't want to miss any case. Next question is, which of the following is an example of case finding or opportunistic screening? That is the screening of tuberculosis in a community setting, screening of hypertension in a patient who is visiting for a routine health checkup, the performing the universal blood pressure screening in a population, and the screening of newborns for metabolic disorders. So what we have learned about the opportunistic screening, that we are utilizing the opportunity as the patient is coming to the hospital. So the answer would be B here. So this is the answer of the first question which I have given you, and these are the answer of question number 2.